Welcome, everybody. Happy Wednesday. Thank you for joining me and Stefan, Sukriti, and Travis, Gabriela, and all the other clinical problem solvers everywhere. How's everyone doing today? James, good to hear. Thank you, James. So as always, we'll look for a case that someone wants to share, as well as two discussants. And in the meantime, we don't have any sort of formal space learning to share this morning, but we could randomly share some thoughts. But I'd love even more to just hear from everybody else called in. Does someone want to share a good moment or a challenging moment or an interesting tidbit they learned from a patient or from somewhere else today? And even if you don't reach your threshold to share publicly, it's a good time to just think to yourself and wonder what was something interesting or new recently. But I hope someone will share. What's going on with you today, Steph?
I am on the inpatient service now, and it's a team that admits every day. So we saw some new admissions this morning that they got late in the day yesterday. Always a lot of fun. It's a small team of just some upper level residents who are later in their training. I love working with big teams with students and a lot of people. That it's a very different feel, just sort of thinking on the fly and really enjoyable. If we don't end up having a case, I've got a cold case I'm grappling with that could certainly share with you guys if we're stuck, but one of our interesting new ones. But it's been good. Our COVID numbers are, knock on wood, down in Houston now, although unfortunately, today is the first day where the state mask mandate has been removed. In Houston, I think pretty much all businesses and certainly hospitals, healthcare enterprises are maintaining 100% masking, but we will see how this experiment goes for the state at large, which unfortunately in the United States counts for almost 10% of the COVID deaths of the last year, quite a large number of cases. So we won't be saying mission accomplished yet, I think, even as vaccination rates come up. James will be excited to discuss with you. Thank you.
In the meantime, while we will wait for a couple more people, hopefully, to volunteer, I'll just share some reflections that were jumping around my head this morning. Nick Young from the Carolinas University posted on Twitter about just reflecting on the difference of a statement like the number needed to treat is only 20, which is something that we hear not infrequently right in our conversations. So the number needed to treat reflects sort of the absolute effect size of an intervention. So if mortality is reduced from 80% absolute mortality to 70% absolute mortality, then that's a 10% mortality difference. And that's a number needed to treat of 10 people to save one of those people's lives with that condition receiving that intervention, right? And in medicine, so many of the things we do have a number needed to treat of, in the hundreds, if not thousands, for things like screening. So truly, especially when it comes to something like mortality, a number needed to treat of 10 or even 20 is quite low. But what Nick was saying is that the other way to look at that same number is that is the the subtraction from 100%, right? So if the absolute effect size is 5%, number needed to treat of 20, that means the intended intervention failed to achieve the intended outcome in 95% of the times that you are using that intervention, which sounds a lot less rosy, doesn't it? So it certainly instills a lot of humility, I think, to look at the same sort of values from those two different angles. But I was thinking about, what are some things that have a number needed to treat of 1, where almost certainly you can have the intended effect of your intervention. I think just how we act and how we relate to patients and how we communicate with patients at the bedside has a number needed to treat of 1 with respect to making the patient feel cared for, making the patient feel respected, and hopefully instilling some degree of hope and optimism for the patient. And I think that is not only a worthy endpoint in and of itself for the patient to feel cared for, but there's also a good evidence that placebo effect, and I don't mean that in a pejorative way at all, has very real and meaningful secondary outcomes on anxiety, on pain, on adherence to therapy, on actual sort of harder quote unquote clinical outcomes. So that was just some sort of personal reflections that I had this morning, thanks to Nick's thoughtful share. How are we doing? Any progress on co-discussants or cases that we can talk about?
Yeah, Gabrielle has a case for us, which we're excited about. James is going to join us discussing, and we're just waiting for one more volunteer to join us in discussion. I don't know if any women out there are interested in hopping on. Robbie, awesome. Would love to discuss with you again. That'll be great. So maybe Robbie first, then James, if you guys want to say hi and introduce yourselves, and then we'll turn it over to Gabrielle for an introduction and we'll get going.
Yes, hello, my name is Ravi Patel. I'm calling from India.
So my name is James. I'm a third-year med student, calling from Arizona. Actually just got off of rotation, so like a little bit tired, but not too tired.
Thanks for being here, both of you guys.
Hi everyone, my name is Gabriel. I'm from Lima, Peru. I'm very excited to be here with you guys today.
Great. All right, we'll get our screen up, and Gabrielle, we'll turn it over to you to share the first part of your case. And I know both Ravi and James are expert discussants at this point, but we always kind of keep the chat minimized just to not get distracted by all the awesome ideas and quick pace in there. Encourage you guys to do the same as we hear from Gabrielle.
Yeah, so I could start with a shift complaint. So this is a 15-year-old boy with a swelling in the right orbital region.
Thanks, Gabriel.
Oh, sorry, I meant orbital, DI.
Carotid. Do you want me to go first?
Sure.
Okay, cool. And then who, James, do you want to pair up? And actually, this is a nice sort of chief concern to just pause and immediately share what goes through our minds, what could be going on with this symptom.
All right, so we have a 15-year-old male, swelling in the right orbital region. So a few things that I would be concerned about is I know that there are like more, I'm lacking on the names right now, but a more superficial infection that tends to not be quite as concerning, since I think it doesn't affect actual deep tissues opposed to an actual orbital infection itself. I feel like I don't have a good grasp on orbital swelling though.
You're
But
spot on, James. Orbital swelling, at least when it comes to infectious orbital swelling, orbital cellulitis, is there's sort of a dichotomous kind of division, categorizing it as preseptal versus postseptal infection. And the septum, that just means wall, right? And basically that tissue plane divides what is more the superficial soft tissue structures, in and around the orbit, versus the slightly deeper and more kind of formally, truly orbit sort of tissue planes that can be involved. And a lot of times that distinction not only determines the severity of the infection, but the pathophysiology and the mechanism, and thus the microbiology, can be slightly different too in those two different types of orbital or sort of periocular infection. And specifically, when you have a more superficial infection, preseptal cellulitis, a lot of times the infectious originates from the skin and goes inwards. So it often starts with a history of a scratch or some little trauma that caused skin flora to cause infection. And the flora there is similar to cellulitis anywhere else, right? Staph and strep, or I should maybe reverse that order, strep and staph. That would be most common. By contrast, a lot of deeper orbital infections actually arise from the sinus, essentially, and track sort of inside outward. And those are more the sinopulmonary kind of flora, things like pneumococcus and some of the other colonizers, the same organisms that cause sinusitis and community-acquired pneumonia and stuff like that. So what about non-infectious things? Could anything cause kind of orbital or eye swelling, James, that is not infectious?
yeah, so potentially, and most of these also kind of would occur like bilaterally, at least the ones that I'm thinking of, like an allergic reaction, or even sometimes, even though it's not really swelling, it's also bruising too, if there happen to be like a basilar fracture that can cause fluid retention in the eyes and cause swelling in the eyes. But then a few things that could cause orbital swelling also, like there are some autoimmune that can cause like uveitis that are independent of infection. And I'm lacking on the name of the one right now. It starts with the R, associated with chlamydia, gonorrhea. It's one of the also, I think there's like an association with one, either IBD or I can't think of the name though. Not Rett syndrome, but Reiter's maybe.
Yes. I love your thinking there, and let me try to sort of clarify some of those things. I think you might be thinking of reactive arthritis, right? Formerly known as Reiter's, where it's an immunologic. It's more of an actual like eyeball inflammatory syndrome of inflammation of the uveal tract, and that is often associated with arthritis and urethral inflammation in a post-infectious sort of setting after gonorrheal or chlamydial or other infections. And that could be described by a patient as sort of eye swelling, but again, the inflammation is really more of the eye and its outer layers rather than the orbit. So we'll have to just get a little bit more detail on the history, the description, and certainly the physical exam to see if this is an eyeball problem or if this is a tissues around the eyeball problem, right? But your other thinking about the tissues around the eyeball, I actually love that you introduced the possibility of bilateral processes presenting unilaterally. So a lot of systemic or sort of diffuse metabolic problems that you would think would affect both sides in all areas at the same time do very often present initially unilaterally, just because there's an inherent asymmetry within people's anatomy, within people's sort of baseline tissue structure and stuff, as well as just kind of practical things. So say this is just hydrostatic swelling, right? Say this is nephrotic syndrome. that tends to be more pronounced in the swelling tends to be more pronounced in the periorbital region, right? The eyelids and the eyes and stuff. And what if this young man tends to sleep on his right side? Wouldn't you think that his right eye would be more swollen than his left eye in the mornings? And perhaps the left isn't so swollen to notice yet, right? And maybe the right is just more pronounced, and that's what we're seeing now. Similarly, Graves' ophthalmopathy and Graves' orbitopathy, the swelling of the sort of periocular or orbital tissues that causes that bulging of the eye is very often unilateral, at least initially. So you're absolutely right to consider those things.
And actually,
go ahead.
And then I was going to say, even thinking to edema, now I know one process along with causing increased permeability in the vasculature would also be obstruction. So maybe even something that's obstructing some of the venous tracts that are draining the right orbit in particular. So some kind of mass effect from something either in the sinuses or even in the like brain parenchyma.
I love it.
Something
I
of
love
that
it.
nature.
So that's spot on. Definitely one mechanism that could result in this. And then you using the word mass effect, I think, is really important to consider. Orbital or retroorbital tumors themselves that could directly be causing the swelling or the bulging. And then one of the inflammatory conditions that is in differential diagnosis is this kind of clumsy term of orbital pseudotumor, right? Where it looks like there's sort of a tumor or swelling, some mass effect causing unilateral orbital swelling. The newer term for that is idiopathic orbital inflammation. And sometimes that can present as an isolated entity, but often it is part of the spectrum of a more systemic disease, specifically IgG4 related disease. So I think there's a sort of a differential already that, just to summarize, includes infectious, autoinflammatory, neoplastic, as well as vascular or other systemic disorders that can cause unilateral or at least asymmetric orbit swelling. And a lot of what's going to help us to make progress on the case is more history, most importantly about the time course, right? As well as some of the associated findings, both locally as well as systemically. So why don't we get more of that history and go from there?
Yes, awesome discussion, guys. So the history started 2 months ago with a right orbital swelling, and then 1 month ago, he started having a left scapular swelling. When he came to the hospital, it was noted as suppuration in the right superior eyelid, and he was hospitalized in the trauma section, and ophthalmology also did make a abscess drainage, and he was treated with doxycycline, and the scapular abscess was also drained. Then clindamycin was given, but it didn't improve. Suppuration continued in the superior eyelid and in the scapular region. He's a soccer player. It was a history of trauma was asked, but he didn't report any. Not from an unusual trauma. I mean, he could have like a kick with a ball, but nothing that like unusual trauma. From the past medical history, he had hepatitis when he was 4 years old. He had chickenpox recently, one month ago. He also has asthma, treated with albuterol. And in medications, he's currently using clindamycin and doxycycline with no improvement. He lives in Lima, Peru. He's from Peru. maybe do you want guys what the physical exam also? Or
Whatever you think is the right amount, up to you.
oh, okay, I can give you the physical exam. The so let me find it. Okay, so he had a temperature of 37 Celsius, a heart rate of 110, respiratory rate was 18, saturation of oxygen was 99, and in the general appearance, he looks active. He looks, he had a good appearance. There was noted obviously a erythematous lesion in the left scapular and also in the eyelid with suppuration. He had also lymphadenopathy, cervical lymphadenopathy, with 3 centimeters of ganglions. Also, there was noted a swelling in the left malleolus, on the left intermalleolus, apart from the scapular and the superior orbital region.
Wow, this case is suddenly going in a very different direction. I really enjoyed James and Zavin's discussion, focusing on the eye with just a nice overview of just anatomically the causes, as well as the different categories of kind of infectious versus non-infectious inflammation. So Ravi, you and I have got a lot more to work with now to move forward about how to unify all these symptoms. So why don't I turn it over to you, Ravi, specifically for just comments on the additional history that we got first.
Yeah, thank you. Great information. In terms of the etiology, what we have already discussed, the vascular infections, inflammatory, and tumor, with the information Gabriel have provided, to me, the infection etiology would be on top of my list. Especially, particularly, I'm thinking of for herpes zoster. Going by step by, I don't want to anchor on the herpes, but going by step, I was also thinking of orbital cellulitis, preceptoral infection. Step by step fashion, right orbital swelling for one. First, she had for 2 months ago. Given the history as a soccer player, I know he didn't report any trauma, but perhaps he may not be knowledgeable that he had a trauma. Right orbital region is present 2 months ago, this swelling, and 1 month ago he had a left scapular swelling. An ophthalmology consult was obtained, and there was an abscess in the right eyelid, which was drained, and he was treated with antibiotics. However, which did not improve. They said suppuration of eyelids and scapular region did not improve. So I'm already thinking perhaps the antibiotics did not treat the right bug, or maybe perhaps the infection has spread in the inside the eye, like orbital cellulitis, or perhaps I was thinking like viral infection like herpes. Past medical history, he does have hepatitis at age 4 years of age. So he may have like a liver pathology. It could be cirrhosis, but he's very young, 15, to cause cirrhosis at this age. Chickenpox 1 month ago. That's what I'm thinking. Perhaps you may have a complication of this chickenpox, like herpes, ophthalmoplegia, like in the eye area. Asthma has been treated with albuterol. However, he denied any shortness of breath or cough. Medications, clindamycin and doxycycline. The clindamycin should treat anaerobic coverage, and doxycycline should have MRSA coverage. I'm thinking that the bacterial infection should be treated if it's truly a bacterial infection. I'm thinking maybe perhaps that's why other etiologies like viral infection is causing this eye swelling. In temperature 37 Celsius. I'm always concerned about sepsis. His heart rate is 110, but he's saturating okay. He doesn't have any ARDS or like true systemic infection, but he's tachycardic. That means he's in distress from swelling of the eye. It looks well. That's good sign, reassuring that he's not septic. HENT in examination, he does have the erythematosus lesions in the eyelid with suppuration and cervical lymphadenopathy. Yeah, so these lesions is a vessel or multiple lesions. The two lesions. I don't want to keep on going. I'm sorry, I keep on saying this herpes ophthalmoplegia, but that's the only thing I can think of. Other lesions could be like maybe uh, maybe they just bacterial infection or like cellulitis if it's erythematous and it's swollen. And next is the swelling over left medial malleolus, erythema, and separation over scapular region. Uh, Perhaps he had a trauma. He's a soccer player. It caused the trauma to the left medial malleolus and ankle twisting. That could be the origin of the infection and spreading systemically. Thank you. Those are my thoughts.
Ravi, what a fantastic tour through kind of the history all the way through the exam of this persistent syndrome, right? Of a recurrent, it sounds like abscesses. And I want to tease apart, I think you've really laid the groundwork for a framework of how we can think about someone whose treatment hasn't worked for them and continues to have an ongoing syndrome. You really, through your thinking, laid out kind of three big categories that I want to tease apart a little more. The first one is, was the treatment itself wrong? The diagnosis perhaps of that bacterial abscesses was correct, but they just didn't have the kind of right antibiotic or the right sensitivity of the organism for the treatment. So, was the treatment just not the right one? You brought up very nicely, though, that the challenge of the treatment not working could have been the wrong kind of organism being considered for an infectious syndrome. And you pointed out he's had a recent viral infection, and so making sure sequelae of having varicella in the form of chickenpox isn't at play here. And then I think we'll have to sort of open up this category even more to other both bacterial and non-bacterial infectious categories that could account for these recurrent abscesses without improvement on the antibiotics he got. So you tackled wrong treatment, wrong kind of organism diagnosis. And then you hinted at the question of, does this young man actually have an underlying condition that makes him at risk for these recurrent infections, even when they're both diagnosed and treated correctly? And you brought up the example of an acquired kind of immune deficiency condition in the form of wondering about if he had cirrhosis from his hepatitis at a young age. Hopefully not, as a kind of young guy who's fit and still playing soccer. But I think bringing up both acquired reasons for him to have immune deficiency, as well as, given his young age and his teenage years, kind of inherited immune deficiency, or should I say congenital immune deficiency syndromes, is a way to open sort of that third category of, is this recurring because of underlying conditions? So really just nice kind of pathway that you've laid out. And I just want to briefly tackle each of these. In terms of the wrong treatment, it seems like he got an appropriate IND. And I guess, Gabrielle, I think I might have missed this. Was it culture negative, or did they not have a clear bacterial diagnosis from that ophthalmology procedure?
Yeah, they did a gram stain that showed cocci in a chain pattern, but it wasn't certain because they wasn't sure if maybe it was from a contaminated sample, but the cultures were negative. from bacteria. They did cultures and were negative.
Thank you. So makes a lot of sense, right? We heard James and Zavin talk about the most common reason someone would have a superficial infection would be a skin organism going through. So with that gram stain data concerning for the gram positives that live in the skin, you know, choosing antibiotics with doxycycline makes a lot of sense, but very interesting. The culture didn't grow anything. So I think that kind of opens up this category of what else could cause recurrent abscesses in this young man. And we kind of talked through sort of in the prior cases, thinking very deliberately through the microbiologic categories. Ravi has mentioned kind of worrying about ongoing viral infection. To me, the sort of focality of these on the right eyelid, on the left shoulder, and maybe on the left ankle, it doesn't sort of fit for me in terms of like a kind of typical herpetic lesion pattern. So to me, the viral category has a question mark over it, but thinking of other kind of bacteria that don't grow well as culture, things that are fastidious, thinking about the mycobacterial category as well, both tuberculous and non-tuberculous forms. And then certainly thinking about sort of if fungi could be at play, although again, we'd have to wonder what puts this young man at risk. And then just in terms of the underlying conditions, I won't go into it too more because I think we'll have more data to go forward, but you know, he recently both had a pretty, you know, chicken pox, which is common enough in kids, but I think we need to make note that he's just recently had chicken pox infection and now is having potentially recurrent abscesses. So really wanting to kind of expand into the categories of both kind of acquired as well as congenital immune deficiency predisposing. And I will really hope to stand on James and Zavin's and Ravi's shoulders in terms of just breaking down those categories even more. But I think we really need to take that recent chicken pox into account with this ongoing syndrome also. With really on the exam, I won't add too much to what you said, Ravi. I think I want to clarify from Gabrielle, is that swelling over the left ankle? Is it the ankle itself that's swollen, or is it also another kind of superficial, what might be an abscess on the outside of the ankle area?
They describe it as a cold abscess in the left malleolus.
A cold abscess. Interesting. So an extension of this process we've now seen in 2 other places of the body. So I think at this point, we can move forward and get some more data, but I certainly think getting broader diagnostic tests on the fluid that can come out of these regions is going to be very helpful. Looking at this young man's blood cell counts and sort of seeing if there's a pattern there concerning for a background hematologic malignancy, making sure we're not worried about you know, other conditions that can predispose them to infections like cortisol excess based on his chemistry. I think the labs will help us a lot figure out what direction to go in here. And yeah, just sort of tackle this nice broad foundation of the differential diagnosis that Ravi gave us. So let's get some more info from you, Gabrielle.
Awesome. So hemoglobin was 12. Platelet count was elevated, 700,000. Leukocytes were 9,700. And segmented neutrophils were 74%. Lymphocytes were 21%. No eosinophilia, 1%. Eosinophils were 1%. Erythrocyte sedimentation rate was 30. Oh, I meant 30. 30. They were also concerned of immunosuppression, so they did a HIV ELISA, which was negative. They were also thinking about Brucella, but all the Brucella tests were negative. And as I said before, they were also concerned for maybe a staph and but the cultures were negative, although the sample showed cocci in a chain pattern. But that could be contaminated with strep epidermidis, they thought. I have some images that I would like to show. In the meantime, the X-ray showed apical consolidation in the right lung. The CT also showed the same. And I will explain the scintigraphy, the scintigraphy image that I have. Could you guys allow me to share my screen for a minute, please?
Yes.
Yeah, just a minute.
Gabriel, this case is getting better and better. Amazing.
So the X-ray showed the apical region in the right lung. And the CT also showed the same. A consolidation in the mostly in the upper region in the right lung. Radiography showed like a loss of continuation in the supraorbital arc, as you can see, guys. Like here, there's clearly a delimitation, but here it isn't. The scintigraphy showed a pathological uptake in the contrast in the right supraorbital region, like here, and in the left scapular region, like here. And also, this is a posterior view, so also there was noted a pathological contrast in the left tarsal bones, and also in the right. And it was interesting because there was also pathological uptake in the right ilium, like here.
Thank you, Gabriel.
What great images. Thanks for
yeah.
having those.
James, I fully expect you to immediately name a certain diagnosis.
Well, so especially given the region of Peru and the apical lung mass, definitely thinking about tuberculosis a lot more, and maybe a disseminated, was it militiary tuberculosis, so like a disseminated TB infection, is definitely would be on the top of my differential. And you know, other things that can cause lung masses, especially with in the region that he's in. One thing I always think about, especially we have a lot out in Arizona here, is cocci also, because that can cause anything from what I'm told. And so try not to anchor just solely on the TB. And so for the scintigraphy, I'm actually a little bit less familiar with that. I'm not sure if that is capturing like specific images, but then other things that I was thinking about as he was walking through it was since there are the neutrophil count was a little bit higher, lymphocyte a little bit lower, with some kind of malignant process that was disseminated, or even a leukocyte adhesion deficiency, probably a little bit lower since of his age. But I saw the cold abscesses, so that was one thing I was kind of thinking as he was talking through it. But mostly for this, I'd be thinking about tuberculosis.
Wow. Yeah, James, I was hoping you would name a certain diagnosis because I certainly don't have one, and it would be nice to be rescued from this complex case. And I think in real life, I would be, seeking a lot of input and help, both from general medicine colleagues as well as subspecialists in infectious diseases, as well as maybe, immunology, rheumatology. Yeah, I mean, I think when you have, certainly an upper lung lesion in an endemic-ish setting and symptoms everywhere else that are super weird, TB absolutely has to be on the differential, and I think very much is here. Some other
And,
micro.
oh, and I was actually even going to say, I mean, I know that it'd be atypical for, a consolidation or just pneumonia, but I know that, I mean, since he's 15, I mean, he's kind of like more a older child, I guess you say. I know that for a lot of osteomyelitis, that tends to spread hematogonously in children, opposed to being caused by a local source like in adults.
Yeah, you bet. Yeah, so I think, TB sort of fits some of these patterns, and I think, would also explain the fact that there's not as much kind of severe inflammation locally as you would expect from a more typical kind of pyogenic bacterial cause. It may explain more the time course and the failure to resolve with the antibiotics that were used. The one thing that seems to be a bit of a coincidence is why the patient may have had chickenpox and then followed by, tuberculosis. I don't necessarily think of, certainly the portal of entry of tuberculosis, of Mycobacteria tuberculosis, is not the skin, right? So, this narrative, the story of I had essentially, a bunch of blisters everywhere and a breakdown of my normal skin barriers, and then I started having a soft tissue infection, really tells more of a story of like some bacteria that you're normally exposed to in the environment on your skin, then taking advantage of that, of those blisters, of those portals of entry, and then causing infections. And that is very well described. After chickenpox, it's not uncommon to have, impetigo, right? Just superficial strep infections, or deeper infections, abscesses, osteomyelitis, pneumonia. A lot of those have been described after chickenpox beats up some of your skin and mucosal barriers. So for TB, that doesn't fit as well, at least within the limits of my understanding of it. But I think other mycobacterial infections, like Mycobacteria abscesses and some of those like slow and fast growing non-tuberculous mycobacteria that are maybe more prone to cause skin infections. But for those, I don't necessarily think of them causing, as much lung or pneumonia involvement. I don't know if anybody can fill in that knowledge gap. Yeah, moving along from mycobacteria, anytime you see involvement of lung and skin, lung and CNS and skin, you want to think of nocardia. Those are the three most commonly involved organs by nocardia. And that is sort of an environmental pathogen that you can pick up here and there. Usually it occurs in people with underlying immunocompromise, but not 100% of the time. And maybe there's still some immunocompromising condition in this patient that is predisposing both to the varicella, as Steph rightfully pointed out, as well as to what's going on now. So maybe those are related, but not by A causing B. It's by C causing both A and B. For a while I was thinking like, this is just probably statistically likely to be, streptococcal or some other bacterial super infection. Doxycycline, for example, isn't the best, agent to be treating strep. But yeah, I think with the lung lesions, as well as now with seemingly involvement of the joints. And by the way, Gabriel, would you clarify real quick what you're referring to as scintigraphy? Is that the same as a tagged white blood cell scan?
Sorry, Steven, I didn't understand it.
Is the scintigraphy that you showed, the images, is that the same thing as a tagged white blood cell scan?
Oh, I don't know that term, sorry.
Okay, okay. I think it might be. That's what the images kind of looked like. It's basically, you know, a radioactive, scintillating kind of tracers attached to inflammatory cells, leukocytes, and then you sort of deploy that and then scan and see where the inflammation goes. And I think wherever there's either infection or other kind of inflammation, that's what lights up on this on the scan. So anyway, so I think overall, this is not as typical for a typical pyogenic bacterial infection. You're absolutely right, James. You know, any of those endemic dimorphic fungi like histo and cocci, and in this case, perhaps paracoccidiomycosis, I think can mimic any of the syndromes that tuberculosis can cause. So I think that should be on a differential. And then finally, in terms of, you know, congenital immunodeficient states, you know, I think a few people have mentioned the leukocyte adhesion syndromes. The two things that come to mind for kind of recurrent infections or, you know, abscesses that don't exhibit as much inflammation as normally. I think chronic granulomatous disease can cause that syndrome as well as hyper IgE syndrome, also known as Job's syndrome. I think that may be associated with asthma as well, and certain sort of phenotypic features. But this is where I would need to do sort of a lot of additional reading as well as consultation with specialists. I'm kind of drawing a blank in terms of what non-infectious syndromes could present this way. So that's, I won't even attempt to make any guesses there. You know, at some point I was thinking, could these skin lesions actually be neutrophilic dermatoses? You know, sort of sweet syndrome or pyoderma gangrenosum, and they're actually underlying with, you know, associated with an underlying malignancy in the chest or elsewhere. But then the joints lighting up doesn't necessarily, you know, fit as well. So I'm a little bit stumped, and I do agree with Steph. I think we need to definitely go all the way in terms of trying to isolate a bacteria from these fluids, and that goes for, you know, both mycobacterial fungal cultures. Since we have a disseminated disease, I think getting systemic fungal markers may be helpful. If available, a PCR, sort of a universal PCR of the fluid may be diagnostic. And then certain serologic testing, both for the fungi and the nocardia may, actually, I don't know if you ever do that for nocardia serology, but yeah, that's all I got, I think, for now. And let's see what Gabriel can tell us and teach us next.
Yeah, so I loved what you guys said about that this patient didn't look septic, so a pyogenic bacteria would be less likely. And also linking with the collapses and the lung lesion, they did a gene expert, and it was positive for Mycobacterium tuberculosis. But most importantly, what I learned from this case, it was chickenpox can cause a transient immunosuppression that can predispose patients to have lots of infections later. And here in Peru, there are reported cases of Mycobacterium tuberculosis with a past history of chickenpox. And chickenpox, the vaccine here in Peru was recently introduced in 2018, so people here still have chickenpox. So it's a important fact to take in consideration. And I also loved about your differentials. I was reading in the chat Sporothrix and Paracoccidio, but they are not endemic in Lima, and the patient did not have travel history to endemic areas such as high jungle, high altitude in jungle, that those climates are more endemic for those infectious diseases. And this was a short case, but I hope you like it.
What a fantastic case. And thank you for the teaching point about the transient immune suppression after the varicella infection. I didn't know that. What a great way to sort of put it all together. Should we do a reflection from Ravi and James? And then
Absolutely.
I don't know if Robbie first, if you want to just share a reflection on your thinking through the case, and then we can have James do the same, and we can turn it over to Gabi for some summary for us.
Yeah, my reflection is that thank you for presenting the case. Yes, it's an interesting case, miliary tuberculosis, presenting as a swelling, the eye, and abscesses. The only thing was I was thinking tuberculosis also, given the history of, given the chest X-ray found apical consolidation in the right lung. Yes, thank you for teaching us. I didn't know either the chickenpox 1 month ago caused his immunosuppression, and then he had this tuberculosis. Thank you.
Thanks, Robbie.
Yeah, and for my reflection, I'd say that it was definitely eye-opening for me to know that I may have to go back and kind of look back at my like orbital and like ears, eyes, nose, throat kind of infections, and get my differential a little bit more down for that. But then also and other things that I sometimes forget to consider in some patients. And for him, obviously he wasn't febrile, but definitely start thinking when we're seeing abscesses or disseminated infections without a fever to start thinking about some kind of immunodeficiencies or something. And in this case, it was probably kind of a immunosuppression secondary to that the zoster's virus. And so, yeah, it was kind of a wild case.
Yeah. Thanks, James. Gabi, let's turn it over to you.
Actually, a quick question to Gabriel. Was the gene expert done, was that on sputum or was that on exudate from the skin?
It was from sputum. And they also did acid-fast bacilli. They noted acid-fast bacilli in the abscesses.
Okay, cool.
And did they end up sampling the lymph nodes also?
No, the lymph nodes, I'm not sure about it, but they did acid-fast bacilli of the abscesses. It was very highly suggestive of mycobacterial tuberculosis, and the gene expert too. So I think it wasn't needed, but I'm not sure about it.
Thank you. All right, Gabi, looking forward to your teaching points.
Thank you for the case, Gabriel, and thank you guys for the amazing discussion. So I think for me, the first important thing was to learn how to evaluate an orbital swelling. Some important factors to analyze are the localization, if it's unilateral or bilateral, the possible etiologies, and the time course. Some possible etiologies are vascular, infections, inflammatory tumors, or trauma. For infections, it's important to determine the localization, pre-septal or post-septal, because this is going to change possibly our treatment, and it determines how the infection was caused, from inside to the outside or from the outside to the inside. It's also important to remember, this is something very, very interesting that I learned today, that systemic and diffuse problems can present first unilateral and then goes to bilateral. For example, nephrotic syndrome and Graves can initiate in only one side and then go to the other side. And factors, for example, for the nephrotic syndrome, the position in which the patient sleeps is going to change where it's going to present. Also, this patient had treatment resistant for the eye abscess. So we can think about if this person had the wrong treatment, the wrong antibiotics, or did he take all the antibiotics that he was prescribed, or did they think about a wrong bacteria or wrong pathogen, or if the person has an underlying condition causing recurrent symptoms, for example, immunodeficiency. It's also important to remember that negative cultures can be caused by fungi, mycobacteria, and also in some viruses infections. This case, the person had an upper lung lesion in an endemic setting and systemic symptoms, and we thought about TB because of these combination of symptoms. Also, a differential that we can have in our mind is about infections causes of lung, skin, and CNS that we have to think about nocardia, especially in immunocompromised patients. And what we learned from this case was also that chickenpox can cause a transient immunosuppression that can predispose to infections like this patient had. Thank you, everyone.
Thank you. And thanks to everyone for joining today. Gabrielle, fantastic case. And James and Robbie, great clinical thinking as always. A pleasure. Look forward to seeing you guys next week.
Thank you. I'm actually looking through the chat now. It's there's a lot of cool things that people were posting, and definitely things kind of want to look into.
Definitely. We always scroll through the chat and learn a lot at the end of every case. Glad you're doing the same. Thanks,
Yeah,
guys.
like the chronic non-bacterial osteo. Never heard of that before. So, but
I'm always
thank you guys.
something afterwards.
Yeah, that's what I'm about to be doing. But all right, well, thank you again.
Bye, guys.
Bye, everyone.